Dr. Rajiv is the chairman of the Division of Peripheral Vascular and Endovascular Services at Medanta at Gurgaon. He is one of the most renowned and senior most vascular surgeon of the city. And he specializes both in open vascular surgeries and endovascular procedures, and has been attending and is a part of APVIC right from its inception for the last 12 years. He's going to be talking about a very pertinent and topic as in the last 1 year, which is role of low-dose rivaroxaban in critical limb ischemia. And after the COMPASS PAD trial, the role has really become very significant, and we are actually now moving from DAPT to this, one antiplatelet therapy or no antiplatelet therapy and rivaroxaban. So over to you, Dr. Rajiv Parakh.
Thank you, Dr. Khanna. Thank you very much for hosting this absolutely phenomenal meeting year after year for the last 13 years. I actually salute your enthusiasm, especially in these unfortunate COVID times. You've managed to pull off such a fantastic collection of speakers and topics. So without much ado, I will talk about this, as you say, a very pertinent topic, which is rivaroxaban, which has recently been included in the medical armamentarium of peripheral arterial disease. So can we have the next slide, please? So PAD, as it is, that is peripheral arterial disease, as you know, affects millions of patients worldwide, but only 5% of these patients have classical symptoms of intermittent claudication. Most of the symptoms, almost 90-95% of them, either asymptomatic or have no classical symptoms, which amounts to, in 2015, a huge number of 236 million adults in 2015 were the number of patients who were affected with peripheral arterial disease. Next, please. Now, there are huge, next, please. Yeah, so there are huge unanswered questions in the treatment of peripheral arterial disease, because they continue to remain at a very high risk of adverse cardiac events and adverse limb events. And despite the current therapy, which is, as we know, either whether it is single antiplatelet therapy or dual antiplatelet therapy, or even in combination with warfarin, the risk of adverse cardiac as well as limb events remains high. This is the REACH registry, in which the 2-year outcomes have been mentioned, and I'll just bring your attention to the worsening of claudication, which is seen prior to revascularization in almost about 108 patients, and even after the risk actually continues, and in fact increases after any interventional peripheral intervention, whether it is angioplasty or stenting, as is seen by the by 149 patients who have undergone peripheral angioplasty out of a total of 692. So these patients have actually worsened, because the risk continues despite the current anti-platelet therapy. So next, please. So after peripheral revascularization, the risk of major adverse limb events is substantially increased. Limb events increase rapidly post-procedure, then more slowly after the first year, whereas MI and stroke events increase steadily over the follow-up period. So essentially, immediately after a limb intervention, the risk of adverse limb events is much more than it would be otherwise. Next, please. So there's obviously a huge unmet clinical need for acute limb ischemia, because it occurs, as I said, frequently after revascularization, and can be life-changing because it can lead to hospitalization and even amputation. About 15% of these patients who had acute limb ischemia, even after revascularization, actually unfortunately died or were unable to go home after hospital discharge, because they were either left with amputations, disabling amputations, and they found it difficult to manage at home. And you can see here that the ALI event rate, that is the rate patient years per 100, goes up almost 10 times from before vascularization as after vascularization, as from 0.42 to 4.41. Next, please. So no antithrombotic therapy has demonstrated efficacy for reducing these adverse cardiac or limb events after peripheral revascularization. As you can see with the CASPER trial, in which DAPT or dual antiplatelets along with aspirin and clopidogrel after surgical revascularization, there is a significant increase in patients who have events, post-operative events, and even adding warfarin after surgical revascularization as the Dutch Boer trial. And you can see that there isn't any significant improvement in reduction of the adverse cardiac or limb events. Next, please. So in chronic PAD also, intensified antiplatelet trials did not report and did not even demonstrate significant reduction in limb events. Unfortunately, they weren't up till now any trials which were specifically looking at adverse limb events, apart from the Euclid trial, the one in the center, which tested ticagrelor as well as versus clopidogrel, which showed that there was no reduction in acute limb ischemia or peripheral revascularization when you used either ticagrelor or aspirin clopidogrel. And the clopidogrel versus aspirin in the Capri trial actually did not measure any limb outcomes. Neither did in the Charisma trial with clopidogrel plus aspirin. They only measured the adverse cardiac events, which reduced by 24% and 17% in the Charisma trial. Next, please. So there is a huge unmet clinical need in peripheral arterial disease because the evidence and or guideline perspectives, there is lack of class 1 evidence for antiplatelet or antithrombotics post revascularization, and the majority of these anticoagulant and antiplatelet recommendations are actually derived from extrapolation of coronary artery disease studies. So there's obviously was a huge unmet need for research, newer approaches, and inclusive evidence for issuing strong guideline recommendations for antithrombotic therapy. So this is where we stand last year. Next, please. And this is where rivaroxaban came in. Next, please. Next, please. Yeah, next, please. Yeah, so rivaroxaban came in, and this showed that there was a huge vascular protection which rivaroxaban offered by prevention of disruption of the aerobic mitochondrial metabolism, reduction of arterial stiffness, reduction of endothelial cell senescence, and anti-inflammatory properties. And this, in association with aspirin, actually has changed the management of peripheral arterial disease. Next, please. The landmark trial, which was the COMPASS trial, which Dr. Khanna alluded to, was a dual pathway inhibition. This is the new novel approach, which is called DPI, or dual pathway inhibition. The objective of the COMPASS trial was to determine the efficacy and safety of rivaroxaban, low-dose rivaroxaban plus ASA or ASA alone. And here about 27,000 patients were tested in these three arms, and the anti-thrombotic investigations were stopped 1 year ahead of expectations in February 2017 due to an overwhelming efficacy in the rivaroxaban, low-dose rivaroxaban arm along with aspirin. So this actually shows that there was a huge reduction in the adverse cardiac and limb events when we combined low-dose rivaroxaban along with aspirin. Next, please. So rivaroxaban, the vascular dose of ASA provides superior cardiovascular limb protection, as was shown by the COMPASS trial, because of the reduced adverse cardiac and limb endpoints. The combination of cardiovascular deaths, MI and stroke reduced significantly by nearly 28%, that is a third. Rivaroxaban low dose plus aspirin prevented 1 out of every 2 major adverse limb events, 46% reduction in limb events, including major amputations. This was a huge paradigm shift which occurred and actually gave us a huge ammunition in our fight towards trying to reduce adverse limb and cardiac events. And the consistent results of COMPASS in reducing adverse limb events and vascular interventions, and including total peripheral interventions among individuals who had lower peripheral arterial disease. This was actually then extended to include patients who had actually undergone limb revascularization. So this is, as I said, a continuum, chronic arterial disease continuing to have limb interventions and then continuing thereafter. So the next study, which again changed the complete outlook and actually completed the outlook, next please, is the Voyager trial. The Voyager study was to evaluate the efficacy and safety of rivaroxaban low dose 2.5 twice a day plus aspirin compared with aspirin alone to reduce the risk of thrombotic vascular events in patients with arterial disease, peripheral arterial disease, undergoing peripheral vascular revascularizations, whether endovascular or surgical. These patients underwent a randomized double-blind phase 3 control trial, and the symptomatic patients who underwent surgery were included in this. And this the results, I mean, the completion was December 19, and the results were given out in March 2020. So this actually has really revolutionized our treatment and management of peripheral arterial disease. Next, please. So the key takeaways. Next, please. The key takeaways from the Voyager PAD primary results was that in patients undergoing lower limb extravasations for ischemic symptoms, rivaroxaban 2.5 twice a day with aspirin compared to aspirin alone significantly reduced limb outcomes, including acute limb ischemia, reduced cardiac events up to 28%, reduced limb outcomes up to 46%, and the benefits which were early, which were even consistent over a period of time. And this stretched across major subgroups, including those with critical limb-threatening ischemia. And even it reduced the unplanned limb interventions, which means reduced the emergencies that these patients would have been subjected to had they not been on this combination therapy. And of course, even though rivaroxaban has been added to aspirin, the TIMI major bleeding had no apparent increase, and there was no significant increase in any severe bleeding, such as intracranial hemorrhage or fatal bleeding. So you will agree that both the Compass and the Voyager trial have given us a significant information about how to treat these major, this limb-threatening ischemia with reduction of limb events as well as cardiac events. So thank you very much for your patient hearing. If there are any questions, I'll be very happy to answer. Thank you, Dr. Khanna.
Thank you very much, Dr. Rajiv Parakh.